And Order. Good morning. This is the Health and Social Care Select Committee, back after Parliament's Easter recess. We are in the Grimond Room in Portcullis House in Westminster, and we are a cross-party committee of MPs that scrutinise the work of the department and various other arm's-length bodies, holding various inquiries, as people will know, and we're starting a new one today, which is called NHS Leadership, Performance and Patient Safety. Now, this is the first oral evidence session of this inquiry. Very briefly, what we're interested in getting to is the relationship between the NHS and patient safety. We're looking at how good leadership differs at the different levels. So there are, of course, trusts, which is what patients would most interface with alongside their primary care providers. There are integrated care boards, ICBs. There are primary care networks. There are so many different levels of the NHS in England, all of which have leadership to varying different degrees. So we're interested in all of that. We're interested in looking at the recommendations of various government commission reviews over the years, including CARC in 2019 and Messenger in 2022. So that brings us on to who we have before us today in our first panel, the aforementioned Messenger, General Sir Gordon Messenger, to put it in its fullest term, who is the leader of the Review of Leadership for a Collaborative and Inclusive Future, that was carried out for the government 2 years ago, and Professor Rich Withnall, who is the Chief Executive of the Faculty of Medical Leadership and Management. Thank you very much, gentlemen, for coming and giving evidence to us at the very start of this inquiry. Let's start with you, if we may, General Messenger. How do you reflect now, 2+ years on from your work, and how do you think it has changed, if indeed it has, the thinking around leadership in the NHS?
So I think I and the team around me commenced this review at a time when there was already an understanding in the National Health Service that the workforce needed investment and needed to be treated as a fragile resource in order to get the best from it. And of course, the work that was done to produce things like the People Plan and many other initiatives that came from them were a symptom of that. And what we've seen since the review was published is a conscious effort to tackle some of the recommendations that the review made, and I think that is positive, and I think that's ongoing. If I had to point to the other sides of the ledger, I would say that a great deal of the review centred on developing the right cultures and behaviours across the organisation. I would summarise those as being, firstly, having collaboration and teamwork as the central ethos of the workforce, and secondly, viewing leadership not just as those with the word in the title, but leadership required at every level, from the very top of the NHS England down to the workplace, and that everyone should feel a leader and a team player, a team member. And of course, that cultural shift takes, won't happen in a year, won't happen in 2-3 years. It happens through sort of consistent application of measures to try and seek those cultural improvements.
Thank you. And just to go a bit further back, when you were asked to do this, what was the exam question? What was the problem that the ministers at the time were seeking to answer?
I think it was twofold, and they are the two key questions, is how can we improve patient safety and how can we improve productivity? And are there ways in which we can improve the leadership and management, and that there is a difference there, of the National Health Service to improve both patient safety and improve productivity? That was the exam question.
Okay, and you called for leaders to prioritise patient needs over the needs of the hierarchy. You said looking out, not up. What, in a nutshell, prevents leaders from doing that? Is it culture? Is it personnel?
Others are more expert on this than I, but I would note during the review that we saw a great deal of people focused on meeting stipulations, standards, targets, and invested a huge amount of effort on delivering against those often centrally imposed, not sometimes politically imposed targets, and that was almost always to the detriment of time spent with patients.
Okay. It's fascinating to have you both here, and let's bring in Professor Rich Withnall. So, General Messenger, you were Vice Chief of Defence Staff, you're a Royal Marine. Rich, you're Director of Defence Healthcare at UK Ministry of Defence. So you both come from that world into this world. Is the NHS well led at the moment, Professor Withnall?
Thanks, Mr. Chairman. Firstly, may I just say thank you to you and to the committee. For context, the Faculty of Medical Leadership and Management was established in 2011 by all the medical Royal Colleges, and were endorsed by the Academy as a means of developing leadership. And that flowed from lessons learned after strategic shocks like Bristol Royal Infirmary and Mid-Staffs. And I think we'd all agree that tragic recent events at the Countess of Chester suggest there's still quite a lot of work to do. We're a values-based charity with a professional home for medical leadership in the UK, and our objective is to raise the standards of patient care by improving leadership, because effective leadership saves lives. This is the first time we've been invited to the Select Committee, so thank you very much indeed for that opportunity. As we continue to face intense pressures, and FMLM continues its developmental journey to the Privy Council to become the UK College of Clinical Leadership. But I think, Chair, to your question, there's just a huge amount of pressure within the system which is constraining leaders' abilities to protect patient safety at the moment. I think we all recognise that the NHS has many hierarchies, but actually the organisational structures themselves I don't think should be the end. Cates and Galbraith, as far back as 2007, said organisations are just vehicles to achieve strategic aims. It's not about what the organisation looks like, it's about what they're trying to achieve. And I think we absolutely agree with General Messenger. We think the NHS quadruple aims are appropriate and they're laudable, but the challenges are probably broad and deep. And if we start with demand, we've got 6.3 million patients waiting for 7.5 million treatments at the moment. We've got 75,000 patients waiting more than 65 weeks. And as we've seen in the last 24 hours, children waiting up to a year for treatment have gone up nearly 10,000 since last April and 85% since January 2023. I think we also need to look at society. I think it's a triumph for medicine and for public health that people are living longer, but that comes with more concurrent diseases. We're better at diagnosing things like cancer and ADHD and mental health. So actually leaders need more capacity to be able to treat the extra patients despite, of course, increasing fiscal challenge. And from our perspective, I think the coming year looks financially very challenging. Less than 0.5% growth in spending in real terms, whereas most health economists would advocate probably spending growth of about 3.5%. To keep up with demand. And it's also difficult for leaders to increase productivity when we've got failing infrastructure and we've got outdated equipment.
Yeah, right.
Our capital investments lag behind OECD for decades now. So actually the UK's healthcare productivity has only averaged about a mere 0.9% over the last 25 years. And of course we've got staff shortages and poor morale. I think we should recognise and celebrate the progress, though. I think the fact waiting lists have fallen for the 5th month in a row is good, but that waiting list of 7.54 million is still more than 300,000 than when the Prime Minister announced pledges to reduce waiting.
Is it what you're saying then, that good leadership in a poor context, so where capital spend is desperately needed, the two have to work hand in hand, and you can be the best leader in the world, but in poor infrastructure and with poor workforce, you're going to struggle with. Or to give it a football analogy, you can be Pep Guardiola, but if you're managing Spurs, my team, God help you.
Mr. Chairman, I think that's right, and I'm sure Matthew from Confed will want to make the point again that you can have the best leaders in the world, but when you're trying to run a system that's 100,000 people short, that's a real challenge. You've got to have an A team to put on the pitch, to follow up on your football analogy. I think the other thing that we ought to bear in mind is we have recurrently changed our structures to try and solve this problem. And I'm not sure that really gets to the heart of it. I mean, I think it's right to bring together NHS organisations and local authorities and others to take a collective responsibility. So I'm in favour of ICSs. They've been around in some form or another since 2016. But actually, those leaders, your Pep Guardiola analogy, Mr. Chairman, they're operating without a guidebook. There's variation across leadership because of the challenges that we've outlined, and leaders are trying to do really good work and build on quicksand at the moment. So I think actually what we need is consistent, realistic and long-term funding.
Thank you. Okay, I'm just going to bring in Rachel Maskell in a minute, but just from both of you, given I explained the context of your former professional lives, you were always obviously expecting good leadership within the armed forces. They also have challenges around infrastructure, around numbers, around supply, around kit, but we still need good leadership to happen. What is it's unfair to say what would be your top three things that come from your former world into this world that would move the dial? Start with you, Gordon.
I think, firstly, the sense of pride and belonging in the organisation that I was part of. So I served 36 years in the Royal Marines. It took 5 weeks for me to culturally feel like a Royal Marine, understand the Royal Marines culture, be proud of it for the rest of my career. And I don't think that entry point into the health sector is utilised enough to drive that sense of cultural belonging and pride in what they do. I always felt equally very well managed as in terms of career by the system. Now, sometimes that was great news because I was asked to do things that I wanted to do, but sometimes I was asked to do things that I wouldn't have chosen to do, but were considered to be in the best interests of the system as a whole. And I did them, and I was either rewarded or otherwise for that. And I think that idea that the workforce, above a certain level, needs to be seen as a cross-organisational asset that obviously within tolerances of a very different workforce in the health sector than in the military can be veered and hauled in order to tackle the challenges that are considered the highest priority, in order to put the right skills in the right place to give the best chance of success.
Interesting. And then just you, Professor Withnall, if you had to pick a couple of things from your old life into this context that we're interested in, where would you land?
I think my points, Mr. Chairman, would be through career leadership development. Leadership doesn't happen by mistake in the military. And I think we need to, for example, start on day one of vocational training for clinical people and for non-medical managers, because I think that helps us mitigate current risks of accidental leadership. And I think the second point I would suggest is ring-fencing central monies to fund that leadership training and developmental bundles, because that inspires, that nurtures, that grows leadership talent. So you then have a pathway of people that you can pull through the system. I think the military does that very well.
Brilliant. What a start to our inquiry. Excellent. Rachel Maskell, over to you.
Thank you ever so much, and thank you for joining us today. I want to just kind of reflect back a little bit. Since 2010, we've had 15 different inquiries. Some are ongoing at the moment, all highlighting broadly similar challenges within the system. However, it feels like we've done the diagnosis, but we don't know the treatment. Why haven't we seen the implementation coming through over all of this time? I think particularly back to the work of Robert Francis and right through today to bring about the cultural change that is necessary to ensure patient safety. If I can start with you.
Yes, so I think there are, so firstly, you're right to highlight a number of overlaps between them, and I think it's important that those overlaps are taken into account in the implementation challenges viewed across the totality of the conclusions that the various reviews have made. I think the answer is mostly it's really, really hard to drive cultural change in a hugely complex, non-unitary organisation such as NHSE. And sometimes the complexities and the fear of what I would call second-order effects, i.e. I do something in this part of the system and it's going to have a detrimental effect in this part of the system, sometimes creates a stasis. Mm-hmm. And I think on specifically the issue of driving the right cultures, I think you have to start somewhere, and sometimes that looks quite sort of small and quite insignificant, but it can have big impact. One of the challenges about driving cultural change is it's very hard to quantify it as well. So you can make investments designed around cultural change and behavioural change and invest in the people and invest in leadership. But the outputs of that investment are very rarely quantifiable in a clear-cut way, which happens in other parts of the system when you're building a new hospital or buying a new piece of equipment or whatever. And I think you're never going to get beyond that, and you just have to accept what I think is absolute common sense, that if you have a workforce that is well-led, well-motivated, resilient, inclusive, cares about what it does, self-polices, self-motivates, tackles things through a collective and collaborative approach, you're going to get better patient safety and you're going to get better productivity. And taking the punt and investing in those things, hard though it is, would be my comment on how to move this forward.
Thank you. If I continue.
Thank you, Rachel. I completely support and endorse General Gordon's philosophy of the right leadership being in place at the right levels. I think that's what it's about, but I don't think we're there yet. And I think that's one of the challenges as to why we need to continue to build on this review. I think the recommendations for practical structures and consistency in leadership is really key. There's a risk that we're still facing an inverse care law because the leadership standards are different in different places, and the competence and confidence of leaders are different in different places as well. I think we could do more to promote collaborative behaviours. That's something that we've seen in previous reviews, and we've touched on it briefly with ICSs, but there's more work to be done there. I certainly think we need to, as the review says, recognise and do more to promote equality, diversity and inclusion in our leadership roles. I think we've got a long way to go there. And finally, I think it's about incentivising leaders to be competent and confident and want to take on these really challenging roles. You know, if the General will forgive me, his review is one in a long line of reports, and your own expert panel's evaluation last month was that actually the government still requires improvement to implement all of these patient safety things. So the reviews and the reports are really, really important, but I think what we need now is action. And maybe two other things to mention that I didn't in the answer to the Chair's point. It is around also maintaining clear boundaries between formative leadership developmental support and statutory regulation. Because I think you need to grow people in order to give them the competence and the confidence. And I think that's constraining if that's linked too closely with regulatory business. So there's lots of good recommendations in all of these reports. But I think we now need to do a thematic analysis, drag them all together, and actually invest in some of those developmental actions now.
If I can just stay with you on the point that we've got a very heavily managed NHS, there's no doubt about that, but you're very much talking about leadership. So how do we get the understanding of the differential between management and leadership, and to see the primacy of leadership in driving cultural change in the NHS?
If I may, I'd like to suggest that this is a team sport. And actually, clinical leaders and non-medical managers need to work really closely together. I think if we go back to the CARC review in 2019, there's some really helpful recommendations there around the fit and proper persons test. But I think, with respect, we've got to resist the temptation to perhaps misrepresent the CARC report and, to an extent, General Gordon's review. There have been attacks on NHS leaders, and there's been a bit of a culture of manager bashing step in. I don't actually think we are overmanaged in the NHS. We don't actually know the number of people operating in roles that feature leadership, and I would suggest we need to do research and understand that better. But actually what we do know is that managers make up only 2% of the NHS workforce. If we look in other sectors, it's about 9.5%. But it's about having competent and confident managers to support the team sport. So I think we really need to fully appreciate the top-down pressures that demands are putting on leaders and managers. Back in 2005, Keynes coined a term, goal odyssey, where the situation is goal setting and pursuit can lead to unintended consequences. And I think we're facing that today, actually, all of these years on. And I think we do need, and sorry to keep returning to it, but the evidence suggests that all high-performing healthcare systems need investment in effective management. So I think we actually need to do more to support our NHS managers and our clinical leaders through a regulatory framework to strengthen accountability, because that enhances patient safety. But I think we do need to challenge the narrative that we have too many managers in the NHS and stop manager bashing.
That's a really interesting response, because in your previous responses you were talking about leadership rather than management. So, and I'm trying to differentiate between the two. I'll turn to you.
I only to make the point that there is not a single manager in the NHS that isn't also a leader. The manager is what they do, and leadership is how they do it. And I think it's really unhelpful to differentiate between leaders and managers, because that's just not the reality.
I think they are different qualities, and that's kind of what I'm trying to draw out in being able to drive forward change, whereas a management system clearly is about managing change as opposed to providing the draw up for that leadership of
as I say, I think that every manager has to demonstrate leadership and is a leader in the system.
Right. Can I just move on to just touch on ICBs? Obviously, they're new in the system. They've had significant budget cuts already, and they have been given the impossible task of drawing together different parts of the system between primary, secondary care as well as social care, and working with third sector organisations as well. How do we ensure that the culture is set right within the ICB frameworks to be able to bring the system culture into where it needs to be in keeping patients safe, setting the priorities, and also ensuring that the system is working as one?
So I am not the expert on ICBs, but I can make a couple of comments based on my experience with the review. Is that at the heart of this is establishing this natural awareness of what goes on beyond the particular sector or organisation that one is in, and encouraging a culture of sort of collaboration, not viewing one's own outputs as the only important ones, but recognising that if you want good patient outcomes, then you need to be able to work and understand the realities of others. And then the other thing I would say is that one of the routes towards that is greater fluidity in the workforce between sectors and between organisations, trusts, so that people aren't brought up simply in a particular part of the system, have no real skills or awareness beyond that system, but understand the realities of primary care, the realities of the ambulance trust world, the realities of local government, and there is remarkably little, or I would argue, insufficient fluidity of workforce, which allows those that come to the ICBs to feel part of a community that they've lived their career through.
Right, thank you, Chair.
All right, very good, interesting. Paulette Hamilton.
Right, good morning both. My question is, I'm going to drill down a little bit. I have read the CARC review. Have I said that correctly, Chair?
Yes, you have.
Okay, and in that review, it was published in 2019, I think February, if I remember rightly. And within that review, it had 7 recommendations, but the Department of Health accepted 5 of them, but 2 of the recommendations weren't accepted. Now, I just want to talk about one of the recommendations, because the Department of Health and Social Care, although 2 recommendations were rejected, the one I wanted to talk about was the power to disbar directors for serious misconduct. I know it's been revisited, but what I'd like to ask Professor Rich Withnall is, what are your views on this?
Thank you very much indeed. Look, I think we need to understand public opinion in answering that question. I think the members of the public are still deeply committed to the NHS's founding principles, but I think they've lost confidence in the NHS at the moment. I mean, we've seen the British Social Attitudes Survey. Public satisfaction has fallen to the lowest since records began in 1983. Of course, patient satisfaction and safety are about more than just the regulation of managers, but I think the CARC review is relevant in this context because it did look primarily about preventing unsuitable staff from being redeployed or re-employed in health and social care settings. So I think under the fit and proper persons test, if directors are found to be wanting in some of those areas, then it's important for patient safety that actually actions are taken. But actually, I believe what CARC was saying is that there is a duty on us to develop competencies for directors. There's a need to have, for example, a central database of directors' qualifications and training and appraisals. And we need to expand the definition of what serious misconduct is. Without doing those things, I think there is a risk of sanction overtaking what CARC was actually trying to espouse in those 7 recommendations. So to repeat a point I've made, I think we need to avoid the temptation to misrepresent the CARC report as a justification for manager bashing, but to ensure patient safety if colleagues are found to be incompetent in their roles, or themselves actually are underconfident and not wanting to do those responsibilities, then actually I do believe that sanction is appropriate.
I read this before I bring you in, Sir Gordon Messenger. I read this and my first views were, in any other profession, automatically you would be barred if you've done something that has led to the death or something happening to others. But I can understand what you're saying, things need to be put in place. But the fact that this sanction is being resisted, I'm struggling with that, because my view is, as we see quite a lot of directors that just move from place to place, so they get it wrong in one place and they drift into another job because they know how to answer the questions. So for me, we do need to have some clear sanctions, so they have got markers. Do we not?
I think we do, but those sanctions, I would politely suggest, need to be against an appropriate regulatory framework that sits with accountability and is underpinned by patient safety. So I'm not for any moment suggesting that people that aren't diligently discharging their responsibilities and are therefore culpable in some proven way shouldn't have sanction. But what I'm saying is that we need to recognise that often clinical tragedies are multifactorial, with lots of different influences behind them. And I think it's overly simplistic to just blame a particular manager and apply sanction at that level without looking at the wider context and the wider system.
Fair enough. What I'll do, I'll widen it. Still on the same theme, but so my second question, do you think the way that the Kirk review, I know it's not your particular review, but I'm sure you've got some awareness of it, the way that it's been introduced and it's been implemented, that it's developing a fear culture amongst NHS leaders and will reduce the openness to report issues, problems, or any errors that are made?
So I'm not well qualified to talk about the CARC, but you're right. I'm aware of it. I would just broaden that a little to that point about, if I may, to that point about people feeling reluctant, nervous, wary of highlighting problems that they know exist, can see exist. But in doing so might be raising their profile in the system. They may be pushing their head above the parapet, if you like, when it comes to the apportionment of responsibility for that. I think that's a real shame that is the natural inclination of many. Of course, that's not the case everywhere, but it certainly exists as an instinct. And I do feel that it's a symptom of people not feeling supported, not feeling collectively responsible, and sometimes too alone, so that they feel that if they are the ones that highlight a challenge, that it's on them and the onus becomes on them and the spotlight falls upon them. When I would argue that the best human reaction that one wants in the workplace is when one sees something that's not right, is to rally around those that are on the same team as you and work out how you can overcome it and eradicate it and move beyond it. And I think too often people feel that it's too individual, and I think that's a symptom of a lack of teamwork in the workplace.
So just because I'm going to ask you to answer the same question, but just to avoid, can I thank you for that? That was an excellent answer. But that teamwork piece, that piece where people don't feel it's part of a team, the team, going back to the question that I asked, how do you feel we can develop that team so reduce that fear culture that is definitely there within the health service?
Yeah, thank you. I think the sentiments that the General's expressed are there in the evidence. Yeah. The King's Fund's reported that a third of NHS providers have at least one board-level position vacant at the moment. That's especially worrying for patient safety when that statistic is especially true in trusts with poor performance or quality issues and in special measures. So to remedy that, I think we need to recognise that loss of clinical leadership could be delivering multiple second-order effects. It could be strategic instability, it could be wasting financial resources, it could be further reducing morale. There's a big literature on that. And of course, it's adversely impacting upon quality of care. So I think there are three things that we probably could usefully get after. The first is trying to correct this perceived blame culture in the NHS. I completely agree with General Gordon. I think executives feel exposed if anything goes wrong, even if those things are completely outside of their control. I think the second thing is we need to take active steps to reduce excessive regulation. And I think the third thing is we need to manage unrealistic expectations of what can be achieved in short time frames. The King's Fund's written on this, and they've concluded that all of those things compound to have a negative impact on staff morale. And if you have a negative impact on staff morale, there are second-order consequences for costs and for performance.
That's an excellent place to stop. Chair, over to you.
All right, thanks very much. Let's bring in Paul Blomfield, shall we?
Thanks, Chair. And I want to follow up, if I can, on Paulette's theme with you, General Messenger. Your report talked about staff, among many things. The context in which staff are operating can create a sense of futility and helplessness in the workforce because individuals lack the tools or the ability to rectify what they see going wrong. And the Countess of Chester case, which was mentioned, kind of highlighted that, and the Ombudsman's comments on the case, the number of clinicians who've raised concerns, but nothing happened. That still hasn't gone away. I mean, last year's NHS staff survey reported that only 70% of staff felt confident about, or felt safe raising concerns, and also only 60% thought that the organisation that they worked in would address concerns seriously if they were raised. So we're a long way from where we need to be in creating the culture in which the organisation embraces and welcomes the sort of engagement of staff in raising concerns that your report was seeking to address. I wonder if you could reflect on that and where we need to go now.
So, firstly, I think that they're a great measure. The statistics that you outline there are a great measure of how an organisation feels at the coal face. You know, what the workplace feels like, what individuals feel like, and I don't think they're very attractive statistics in any way, and they need to improve. It touches on that point I made earlier about people not feeling part naturally as a team. Again, this is a generalisation. I know that there are some fabulous teams exist across the board, but too frequently people feel alone. The two behaviours that surprised me the most in the review was the first was this blame culture, this sort of finger pointing in order to offset the focus on you to something or someone else, and that can happen. And the other was what we described in the report as responsibility avoidance, whereby workers and colleagues were coming into work, delivering absolutely to the letter what they needed to deliver, but without any ostensible interest or engagement in what happened beyond their specific work responsibilities, particularly when it came to collective improvement or organisational betterment. And again, one of the observations that the review mentions is that isn't restricted to the level of skill in that workforce, and indeed some of the more highly skilled members of the workforce exhibit similar traits, including senior medical professionals and surgical professionals. And that surprised me as someone who'd had a military career, because those, and I'm not for any second suggesting that all cultures in the military are perfect and don't need, but the issues of responsibility and avoidance and blame cultures aren't often witnessed in the military, and I think there's something about the fact that we naturally gravitate to collective responses, collective cultures, teamwork, belonging, and an ability to be able to rely upon those around you and have confidence that one can, that I didn't think existed strongly enough in the workplace and frequently enough in the workplace in the health sector. And this is what I'm getting after when I talk about, really deep endemic cultural change. How do you really try and break out of that so that people do feel safe, do naturally feel more and more responsibility the more senior and more skilled they get, and are ready to lean in when they see things that need to change.
I think that's very helpful, but what the Letby case showed was that there were a lot of people working at the Countess of Chester who did want to do what you described. They did want to raise their concerns. They did want to be heard when they saw things going wrong, but the system crushed them. And in a sense, that's what's still there in the staff survey numbers from last year. And so how do you achieve that cultural change where the system stops the sort of behaviours which are there?
Yeah, I mean, and I don't know the ins and outs of that case, but I do know that one has to have a system that is receptive, that listens and acts on the sorts of noises that are coming out of the workforce that occurred in that particular case.
Can I ask you one further question, which is a system issue? Because you talked in your report about the pressures which create the sort of organisational instinct to prioritise the needs of the system over patient safety. How far are the metrics that are imposed on the system creating that sort of behaviour? I mean, it's not. We all recognise that we need to measure performance. Are we getting the performance measures right? Is there a contradiction between the metrics that we set and the culture that we want? And could we change the metrics to get the right culture?
So I think that is an important point, and I think it's an important dynamic which extends way beyond simply the completion of the metrics, and I think it does have an impact on that workplace dynamic that I think we've both described. And it's not for me to determine which areas of regulation are more important than others. It's not for me to determine which performance measures are more important. But I would argue that if you have an organisation that is overly performance managed and overly regulated, it becomes a less efficient and a less effective organisation. And I would certainly commend, and I know I'm not alone here, a look at that and a review of the impact it has on the behaviours.
Professor Withnall, I wonder if you'd like to comment on any of the points I've just raised with...
Thank you. If I may, Mr. Bloomfield, I'd like to just pick up on standards a little bit. I mean, I think performance standards can be useful. I think they can help define processes, they can define outcomes. They can help concentrate the minds of those responsible for a service, and of course they can justify investment of taxpayers' money. But I think the other really big point here in terms of patient safety is the need for us to think more about professional or personal performance standards as well. So I agree with the Hewitt review, and I'm pleased that the national NHS planning guidance has reduced from 133 targets in 22-23 to 31 in 23-24, but of course Hewitt's urged a reduction to 10 national targets, and ICS is to set their own priorities, but I think we should invest more in our people. I think it's support for those personal standards that we need, and I'm not sure we're doing quite enough there. So I think we need comprehensive, strategic, developmental standards set by a professional body. I think we need mechanisms to support leaders' professional development and create those psychologically safe spaces for people to raise concerns when they have them. And also, I think it's really important that we support the welfare of our leaders. This is a really difficult job they're doing in very challenging circumstances. So I'm delighted actually yesterday NHS England's extended the NHS Practitioners Health Service, and I think that's really, really important. They saw 32,000 colleagues since they started 16 years ago, so I hope we can shore up long-term support for that particular scheme. But ultimately, I hope that the cross-party support that we've seen for developing FMLM into a College of Clinical Leadership can become a reality, because I think the point of commonality, sir, for all of your different threads there is the need for a pan-NHS, multidisciplinary professional body to provide guidance, assure evidence-based standards, curricular and guidance frameworks. I think we need to benchmark clinical leadership against professional standards. I think we need a membership body that can then provide, if you like, a data set of suitably competent and confident clinical leaders and non-medical managers as well, which will support your recruitment, your promotion and your retention within the NHS leadership roles. And I think if we do that, then that puts us on a better footing to support the improvement in the implementations of all these excellent reviews which your own expert panels actually felt required.
Thank you. Okay, thanks very much. Just then finally from me, talk about the role of clinical staff in leadership. So just sort of draw together your thoughts on this before we move on to our second panel, which we will move seamlessly into, FYI, so be ready. Would we see improvements in patient outcomes if clinical staff played a greater role in leadership? How do we get from A to B on that, Gordon?
I think by investing more in leadership training and development for clinicians, because at the moment it is not as institutionalised, arguably, as it could and should be. There is, I would argue, insufficient leadership training development in the initial training of both nurses and medics. I think that the competencies of clinicians as they go through their career is quite rightly judged against their professional acumen, but it needs to be also judged against their leadership acumen, their behavioural approach to the way they do their business.
You said in recommendation 1, didn't you, the development of a new national induction programme for NHS and social care staff, and the departments say in their response to this inquiry, which we'll publish today, that will be launched in spring 2024. Is that news to you, or are you?
That was. I'm delighted. I'd be interested to see what the nature of it is. I mean, inductions can take many different. That can be toilets and fire escapes, or it can be a sort of cultural and DNA shifting moment in one's career. So I'll be very interested in what it contains. But I think it's
You're saying you haven't had sight of that? You haven't been involved in that?
I have not. No.
Does that surprise you? Disappoint you?
It doesn't. I have been asked by the NHS to support them in some other work, but not specifically that. So I don't feel neglected or ignored by them.
Okay. That's a very good approach to take. Right, okay, there is a final question from Paul Bristow, and then we'll change panels.
Thank you, Chair. I was taken, General Messenger, with the comment that you made around it's common sense to see well-led, if you have a well-led team, you have a well-led workforce, you'll get better productivity, better outcomes. That is, of course, common sense. Why do you think that's a challenge for some in the NHS, not to accept, but to embrace and implement?
So I don't think it's just the issue for the NHS. I'm not suggesting that they don't have tools at their disposal that they can deploy. I think it is often the expectations that are placed upon them by external parties, including politics, whereby they are judged, and perfectly acceptably, against their efficiency and their patient outcome record. They're not necessarily judged about how happy or valued their workforce is. And I just go back to that point I made earlier, how hard it is to sort of quantify investment in achieving a well-led, well-motivated, resilient, inclusive workforce. I'm of the view that one needs to accept it's really hard to quantify that, but one needs to do it anyway, and it needs to be placed in a priority alongside some of those pressing operational challenges, despite the issues of trying to, that golden thread through to impact.
Would you argue that perhaps some of the targets and metrics you were talking about earlier, as well-intentioned as they are making the realisation of that a challenge?
Yes.
Okay. So just final question if I may. So the Lansley Review was stated wanted to take the NHS out of politics, right? So where do you create? How do you solve the tension between the outcome, obviously, that you're wanting to do, the giving staff the headspace and the ability to go out and have that leadership, against political accountability and transparency. Because I would argue political leadership, in many ways, has led to quite often some of the biggest improvements in healthcare. And I'm talking about things like hospital-acquired infections. When you have that sort of political, kind of focus, it has actually led to significant patient safety improvements.
And of course that's true, and of course this is a highly charged and highly relevant political issue. I'm not suggesting otherwise. I think the balance needs to be struck, and the degree to which, and it's not just politics. It's regulator. There are other external pressures which have a similar impact. But I think interventions need to be done collegiately and collectively with the common goal of improvement. And I'm not convinced that's always been the case.
Okay, thanks very much. Right. Thank you very much, General Messenger, Professor Withnall. Thank you for giving evidence to us at the start of this inquiry. Really, really insightful and really, really helpful. We are now going to move on to our next panel. So if you exit stage right, then the next cast will enter stage left. And as they do that and get settled, and we change the names, I will introduce them. We have Matthew Taylor, Chief Executive of the NHS Confederation, who's well known to this select committee and has been before us before. Nice to see you again, Matthew. And we have Rebecca Hilsenrath, who is Chief Executive of the Parliamentary and Health Service Ombudsman. And thank you both for being here. So you've heard the evidence that's been given at the start of this inquiry by panel one. I suppose the place to start, maybe I'll start with you, Rebecca. In your evidence to us, you say that there are some excellent examples of NHS leadership, but, and I quote, there is a long way to go to ensure this culture is embedded consistently across the NHS. So there are good examples of leadership in government, but whether it's everywhere in government is another matter. And it is the challenge, of course, always to see that that happens across government. What then needs to happen, or what do you mean, first of all, when you say that in your evidence, and what needs to happen to ensure that it is embedded consistently, because I think that's the key word that you make there, consistently across the NHS?
Thank you, Chair. So first of all, thank you very much for including me in this session and for inviting me today. And I wanted to start off by saying you're familiar with the work of the Ombudsman. We hear complaints about the NHS, and because of that, our lens is very much looking at what goes wrong. And we are, of course, aware of the many examples of brilliant people across the NHS who are dedicated and do phenomenal things, and we're aware of good practice as well as bad practice. And I also think it's important to recognise the enormous pressures on the NHS recently through the pandemic and other rising levels of demand, but also historically. I think it's also important to recognise that some of the areas of difficulty in NHS are not actually connected to those recent pressures, and they are endemic to some of the issues that you heard about in the recent session. So in terms of saying of talking about inconsistency, we don't see through our casework many great examples of good practice. Otherwise, we wouldn't be looking at issues that have been brought to us as complaints. We do, however, see good practice in terms of the work we do working with stakeholders. And I'll give you just one slightly random anecdotal example, but it brings me on to quite an important point. I've spoken to an NHS chief executive who regularly meets with complainants in relation to his trust, talks to them about what's happened, and understands their perspective and also what happened in terms of the response they got from the trust. This person also employs patient partners, people with lived experience, to oversee responses from the trust to people who've suffered some form of harm. That doesn't happen across the NHS, and we're aware that there are areas where there is very poor response to people who have suffered some sort of harm, and critically, that learning doesn't result because of that defensiveness. And we know that there are areas where they're struggling to perhaps ensure the best leadership and the best candidates at senior level. And what we would like to see is more consistency. We'd like to see better structures that enable some of that really brilliant practice to move across the NHS more consistently. From our perspective, I'm sure we'll work towards this over the session. That focus on working with users, on listening to complainants, is an absolutely critical way to ensure that your service is user-focused and you're really understanding what's going wrong and you're using those experiences to improve your service. And that's the critical thing I think we need to see more consistently across the NHS.
Okay. Matthew, welcome. Is the NHS well led? I know that's a big question because there are so many, as I said in the introduction, so many different layers to it. But take me generally first. Is it well led? And then zoom in on some parts of it, if you will, as to where you think it is and is not.
Well, just to add my thanks for inviting me to the committee, and I think the NHS Confederation is delighted that the committee is looking at this issue. You consistently, as a committee, have demonstrated a capacity to look at issues in the round and to put them in a useful context, and I think it's very important to do that here. I think the NHS is well led. I think any large institution will have a standard distribution of leadership. I think sometimes politicians like to imagine they can abolish the standard distribution, and there won't always be some people who are outstanding, a lot of people who are pretty solid, pretty good, and some people who are finding things difficult, and that's always the case. And the question is, how do you deal with that? How do you enable the leaders who are most successful to be able to spread their practice, spend time with their colleagues? How do you shift the kind of the centre of the curve a little bit to the right, so you're improving what the average is, as it were, and how do you intervene effectively to support those people who are facing challenge, and if necessary to recognise that there are people who are not up to the job? That's what the heart of this is about. And I don't want to repeat the eloquent comments that Rich Withnall made earlier about the context of this, but I would encourage committee members to think about the context, because I think it's material. If you are a leader in the NHS, you are working in the context of a gap between demand and capacity. You are working, for example, in the context of an £11.5 billion maintenance backlog. So many leaders are asking their workers to work in circumstances that are far from satisfactory, indeed in some cases almost dangerous. You're working in a highly centralised and politicised environment. As you all know, the planning guidance for this year for leaders in the NHS arrived the day before the beginning of the new year. I think most people in the health service, recognising the financial settlement, assume that at some point this year there'll have to be more money provided. So yet again, we'll have a situation where you're given some money at the beginning of the year, and then later in the year there's a kind of short-term burst of money because it is essential, which is not a great way of doing things. That for reasons that I entirely understand, the department, NHS England, needs to say that things are getting better and improving, where at the same time public confidence is at an all-time low. But yet we have a duty of candour in that environment, and where all academic research shows that the NHS is undermanaged, but yet on a consistent basis both the media and politicians are prone to do a bit of manager bashing. Now, why does that matter? It matters firstly because it is important that the centre models the leadership that it wants to see. This is not a rhetorical point, but the centre needs to model the leadership that it wants to see in the rest of the system. And one of the issues around things that lead to a certain amount of cynicism is that when you see the centre not behaving in the way that those who are running the organisations are expected to behave. And then secondly, and this is more important, it's vital to take responsibility for the overall ask and expectations that we have of leaders in the health service. We can pour ever more recommendations and targets and incentives in, but it feels to me very rare for anyone to stand back and say, what does this all actually amount to? And the danger is that as we require more, what we develop is a culture of compliance. that all the boards do is try to make sure that they're ticking every single box that is put in front of them. And that in the end is not leadership. Mere compliance in a context that feels very difficult. So I hope that you'll reflect on that. And the second point, just if I might at the beginning to say, is that it's important that we're talking about patient safety here. But I do feel that sometimes the debate about patient safety is separated from a broader conversation about risk. So if I can channel you've kindly said in the past that you listen to Moral Maze, if I can channel my Moral Maze thoughts here. When we talk about patient safety, we use a kind of Kantian framework, which is to say patients must always be safe. It's an absolute imperative. And of course we agree with that. And patient safety is a top priority for leaders. But leaders also are utilitarians. They're also people weighing up different risks which are endemic in a system where you've got 7 million people on waiting lists, tens of thousands of people who have to wait too long in accident emergency departments, hundreds of thousands of young people not getting the mental health intervention they need. So somehow when we talk about safety, we need to talk about in the context of risk overall. And what does that take me to practically? We need to be clearer about risk, and I think we need to be more open with the public than we sometimes are about risk. And I want to give you, just to finish, a very concrete example of this. So in the winter before last, there was an open conversation about the fact that we needed to manage the risk in the system. And what that led to was a recognition by acute leaders that the biggest risk lay in ambulance response times. And what that meant was systems which allowed more people to stay in the emergency department on trolleys, more people to go into wards than were supposed to be in those wards, because in the end, conscientious hospital managers with clear leadership from NHS England understood that, even though that involved risks, and there was always a danger that something would happen and that would lead to an inquiry and condemnation, but actually the risk of having too many people in a ward and too many people in ED was lower than the risk of ambulances taking too long to reach people lying on their living room floor having had a heart attack. We need to have more conversations of that kind about how we weigh up risk, and we need to be more honest with the public about how we manage risk. And that needs to be a context for the conversation about how we get patient safety right.
Really interesting comments. Can we just then touch on the systems, so ICBs. So, I spoke at your conference last year in Manchester with Patricia Hewitt around ICBs, around the time the Hewitt Review came out, and the response to Hewitt from government, which also a response to our inquiry on ICBs. And our inquiry, as you remember, was called ICBs, Autonomy versus Accountability. And you could put it another way, leadership versus compliance.
Yes.
And the reason it was called that was for exactly the reason that we were putting the question, are ICBs about leadership, or are they just the delivery arm of NHS England and therefore they're about complying with those targets? Are ICBs, Matthew, and then Rebecca, are ICBs well led? Notwithstanding, I totally take your point that the context is important, because leadership is in the round. It's a corona. I completely understand that. But your experience of talking to ICBs, how do you feel that system leadership is developing? Because they're still new, of course.
So you quite rightly recognise that they're new. It is really important, in my view, that we stick with this system and let it mature and develop. That they are different. As Jill Morgan, who was the former chair of our ICS network, said, when you've seen one ICS, you've seen one ICS, because they are so different in their scale and nature of their challenges. But I do see great leadership in ICSs. What is the critical leadership factor? I think it is the sense of collaboration, that they have managed to build a sense of collaboration with providers on the one hand and with local government and third sector organisations on the other. Now, as Gordon Messenger said earlier, to achieve that collaborative framework in a system which is under enormous pressure is very difficult. And if I take, for example, social care funding, the issue of hospital discharge, in many places it has just proven incredibly difficult to maintain a positive relationship between the health service and local government, because both sides face impossible challenges in relation to the particular challenges, for example, associated with hospital discharge. But the critical thing is the quality of those relationships. And the thing that gives me a sense of hope is that in many ICSs you are seeing a broader conversation about health. you are seeing a desire to achieve structural change. We have been talking, for example, for 20 years in the health service about how do we move a greater proportion of spending out of the acute sector and upstream into primary, community and prevention. It's incredibly hard to do that when the acute sector is under this pressure, but at least ICSs are trying to grapple seriously with that issue. And I also think, I also welcome the fact that most trust leaders now, there's sometimes a distinction made between system and trust. Most trust leaders have got place or system leadership roles now, and I think that is leading to a change of mindset. So I think good progress has been made, but made in challenging circumstances.
Yeah, that's really interesting. And Rebecca, a very senior MP said to me recently in conversation about ICBs that what we need is reality on the ground and local information, not unfounded optimism. And I think I know where they were coming from is that we often do get unfounded optimism from ICB leadership who want to present a positive picture to MPs of how it's going. But unfounded optimism in a healthcare setting can be very dangerous, can't it?
So thank you. And I mean, echoing some of what Matthew has said, anecdotally and personally, my interaction with ICB leadership has been wholly positive. And I've really welcomed that ability to engage with a different layer of management when looking at, a trust and issues going on in a trust. I don't have a view on ICBs as regards any other structure, but I do note that one of the complexities and challenges in relation to NHS improvement is the changing nature of structures and the local structures versus national structures, and the kind of conflict of accountabilities that can sit in that space. It's really critical in looking at improvement going forward that we take as holistic a view as possible. We know that there's a direct line from top leadership all the way down to frontline patient safety, and we also know that it's very difficult to design a successful intervention at only one part of the system for some of the reasons, again, that Matthew was talking about. So I completely welcome that overarching leadership. And I think I support the view that I think we should let them bed in. I think constant change is the enemy of improvement in the NHS.
Amen to that. And just finally to you, the outgoing Ombudsman said, the detriments that people are experiencing are significant, shouldn't be happening in significant areas: maternity care, mental health, avoidable death, sepsis, eating disorders. Time and again I've come across stories of people who only want the truth about what happened to their loved one, and they've found it very difficult to get it. That's my job, to get at the truth. That doesn't speak well to leadership, does it?
Well,
what did he mean by that?
Just to go back to where I started, we look at complaints across the NHS, and we look at complaints which have already been through local resolution. So by definition, if we look at a complaint, the person who's come to us is not happy with how that's been looked at locally. We published a report last summer called Broken Trust. We laid it in Parliament. What we did is we looked at 400 recent cases and identified 22 cases of avoidable death. In every single one of those cases, this had not been properly recognised at local level, or it wouldn't have come to us. And in those cases, not only had families lost someone that they loved, but there had been a compound trauma because they had not been listened to, the issue had not been recognised, there had been no learning, and this obviously stops you moving on, it stops you grieving properly, and it takes an enormous amount of time and effort to be able to kind of pursue that goal to come to the Ombudsman, and we recognise that. We also recognise that it's such a difficult thing to do that the number of cases that we see will not represent the totality of harm. And coming back to my previous answer, it's the ability of the NHS to learn and improve that is going to be critical to its well-being going forward. And when you talk about reviews, and there have been a number of them recently, including in the maternity space, the critical piece is that they're making the same findings time and time again, and these are not addressed. And if you look at the East Kent report by Bill Kirkup, that started with an open letter saying that everything he was saying he had said 7 years earlier. Was it 7 years? Yeah, 7 years earlier in the Morecambe Bay investigation. And that's the issue. Why aren't NHS trusts learning? And I do think a big part of it is what we see in the cases that come to us, because people have been met with disingenuity, defensiveness, and a sense of being battered away.
As you know, we share that concern, which is why we asked the expert panel to produce a report based on exactly that, patient safety recommendations made by public inquiries and where we are. And it is a matter of record that they said that requires improvement in terms of them being implemented.
Could I, Chair, just very briefly...
Yeah, and then I'm going to bring in Rachel.
I think it's a really good piece of work that you commissioned. I want the committee, however, to avoid the impression that nothing has happened. I mean, we have had the Freedom to Speak Up champions, which is a very comprehensive process, initiative. We have the fit and proper person test. We have the new patient safety, PSERF, the new patient safety framework, which is around trying to create less blame-focused conversations in relation to incidents. We have just today or yesterday announcements about medical examiners. We have the implementation of Martha's Law. Yeah. It's not that nothing is happening. 100%. You know, so I think in a way the question is not so much why is nothing happening, is why is it all of this when it is added together doesn't seem to shift the dial.
Yeah, and of course my question wasn't why is nothing happening. I mean, if we felt that and our expert panel felt that, it wouldn't be requires improvement. It would be even worse. Anyway, Rachel Maskell, over to you.
Thank you ever so much. I want to start, Rebecca, if I could, with you. So the PHSO and the Patient Safety Commissioner wrote to the Secretary of State on the 9th of February, highlighting particularly too many instances which have not been adequately investigated or acknowledged, highlighting there are countless oversight bodies involved in holding the NHS to account and scrutinising it when things go wrong, and obviously highlighting the complexity of the system. And I particularly think of, we've just talked about kind of repeated complaints or repeated CQC reports, and we see the same issues coming up time and time again. What response have you had from the Secretary of State?
And we're still waiting to hear from the Secretary of State at this point.
In that case, what are you hoping to elicit from the letter that you've written?
We made a number of comments in that letter, and obviously there's an enormous complexity about the difficulties in moving forward, and you recognise that. One of the things we asked for was a review of the regulatory landscape. It's really quite challenging to get the health and social care regulators into one room. It's a very fragmented landscape, and to offer a sort of critical view, there's a slightly knee-jerk reaction when things go wrong to set up another body without thinking about, well, actually, might this sit with somebody else? And obviously that there's a kind of efficiency issue there, but there's also an issue of overlapping remits and confusion and additional barriers. And that means that all the individual organisations' voices are weakened, and it means there's a lack of ownership and a lack of clarity and barriers to taking things forward. So we have asked for an overview of that, with a view to making it more uniform, easier to work with, because we think that would be one of the things that would help to take forward some of the issues in the NHS when we're talking about the issue of findings not being learned for. And I would just add one other thing, which slightly comes back to Matthew's point, but also comes back to the letter. We talked about the need for the NHS to listen and to adopt better approaches to complainants and to users generally. And I'm grateful for what you said, Matthew, because there have been some really, really impressive and fantastic advances, but they do connect into leadership. So you talked about the freedom to speak up regime, which we absolutely support and is really important. We do note from the NHS staff survey results that there are reasons for concern about how much people do trust the system, and their confidence that something will happen as a result of a complaint, and their security about making a complaint if they've been involved in an issue. And we would say about that, and we want to say the same thing about complaints, that it is a leadership issue. So if you look at the findings from the National Guardian's Office, there's an inconsistency, which is the word of the morning, obviously. There's an inconsistency about how well supported Freedom to Speak Up guardians are, how much time they get. And I think for the system to work well, it is about leadership giving support. The same thing is true of complaints, which I'm happy to come on to, but when we originally looked into complaints and we talked about complaint standards in that letter to the Secretary of State, we commissioned a report in 2022 called Making Complaints Count. And as part of the research that went towards that report, we spoke to many complaints handling teams across the NHS, and we also spoke to a lot of leaders. And a lot of leaders said, we have a really important complaints handling team and we really value their service. And a lot of complaints handling teams said, well, you know, we don't get valued and we don't get trained and we don't get supported and we don't get developed. So there is a kind of parallel thing there between the freedom to speak up regime, the complaints handling structure. They're great. They all need proper leadership to work.
Thank you for that answer. I also want to draw on your written submission as well, where you say a leadership stance that views complaints as a threat or failure will lead to responses that lack compassion and are characterised by defensiveness rather than a willingness to listen and learn. And I think that's a very astute observation. How do we ensure that organisations move into that listening and learning space? Because obviously that needs to be at the lowest level. In fact, your desk should be empty. Complaints shouldn't be escalated to you. But also, how do we ensure that it is looking for those issues as well? Because I recognise the complaint system is heavily weighted in inequality. So if you have got less agency, you're less likely to complain as well. So how do we ensure that it is looking to address those concerns, not just waiting to be responsive to those that are able to complain?
I completely agree. And I did mention the NHS complaint standards, which we rolled out a couple of years ago. We co-produced with the NHS. And they're all about early resolution, learning culture, ensuring that learning is acted on and reviewed. And there are expectations within that about positively welcoming complaints and about looking at them from a thorough and fair way and in an accountable way and looking at the learning. And that can't be about sitting in your back room and hoping that people are going to come to you. It's got to be a culture within the entirety of the body. And I spoke earlier about an NHS chief exec whom I met who worked with patient partners who employed people lived experience. They had a hub within the hospital welcoming people. They were talking actually about taking premises in the town using one of those charity shops with a kind of high street front and really getting into the community and taking that message out, which I thought was a great idea and it's just an ambition at the moment. I think if you look at some of the repeat findings, which I know make kind of very sad reading because they are repeat findings and they'll be well known to this committee. And you look at some of the maternity inquiries, particularly, they talk about lack of compassion and lack of listening. There's that critical piece about actually listening to patients and families and loved ones and listening to staff. And I think that's got to be the place that you start. But I'd also mention, and then I'm going to pause, General Messenger in the last session talked about teamwork, and he talked about the stark difference between the military culture and the NHS culture in terms of what he experienced as the lack of teamwork. And you see that in the Kirkup findings, because he talked about groups of professionals just not getting on with each other, like obstetricians and midwives or whatever. And that's a massive barrier when it comes to making a complaint. It's a massive barrier when it comes to escalation and referral. It's a massive barrier with producing a culture that is welcoming and makes patients really feel that they're cared for, because what they're hearing is colleagues dismissing each other, and that's always going to take you away from learning.
Thank you so much. Matthew Taylor, if I can turn to you now. One of the things that I think I've heard today when talking about leaders or managers is confidence and being able to act with confidence within the system. And that reflects a discussion I've had recently with an NHS leader who is not able to bring about the change because there is so much pressure being put on the system. What messages have you got for NHS England, for government, in order to ensure that NHS managers and leaders can have the confidence to make those bold decisions which they know they need to, or even the little changes?
Yes, well, thank you. And I think if you look at the literature around what makes for dynamic, continuously improving organisations, I think what you'll find is that the characteristic they have is that they combine and align different drivers of improvement. So top-down drivers, which are to do with strategy, accountability, resource allocation, those kinds of things, capacity to intervene when things go wrong. Lateral drivers, which are to do with professionalism and culture and teamwork and values. And then bottom-up drivers, which are to do with being responsive to patients, to the public, to the community. That's what creates for a dynamic system. And if you want the best leaders, you'll have leaders who feel that what they're being told to do, what people think is the right thing to do, and responding to people aligns and creates a dynamic and improving culture. The reality is that all NHS leaders suffer from the same medical complaint, and they all have stiff necks because they spend all their time looking up. And until we can create a context in which, leaders have more time to learn from each other. One of the things that I find remarkable coming into the NHS from the outside a few years ago is I assume that because the NHS is big and there's lots of different leaders would spend a lot of time in each other's organisations learning about them. They don't. They don't have the time to do it. You know, if I was running the NHS, I would say every leader should spend, one day every 2 months in a different organisation, just learning about it, finding out about it. It's one of the reasons that we recommend a stronger element of peer review in CQC inspections. But I would also want leaders who had more time to listen to patients and to the public and to recognise this is not a problem to be solved, but integral to the improvement of quality. So if we want the leadership, the best leadership, we do have to reduce the amount of central control and compliance. And if a board, and this is not just about leaders, but it's about boards, if nearly all that boards do is worry about compliance, you are going to get compliance and not leadership. Mm-hmm. And that is one of the reasons why I think ultimately the NHS is not as responsive and dynamic as it needs to be. And, for my own organisation, the NHS Confederation, we are turning ourselves from an advocacy organisation into one that is around how do we strengthen peer-to-peer challenge and improvement, because that is a kind of missing element in all of this. I know that when leaders sit around a table, listening to each other, looking at data, they really can learn a lot. But they rarely do that. They more often are in rooms where they're being told, this is the way to do it, now go back and comply with this list of instructions.
Can I say that I do agree with that, and I think when we look at safe spaces and psychological safety, that applies to leaders as well as those that they lead. And I mentioned really quickly, anecdotally, 3 behaviours that we've seen at leadership level. One is a concern about findings about an NHS trust because they worried that it would damage reputation and patients' willingness to come and be treated at that hospital, as opposed to accepting the recommendations and making the improvements. Secondly, refusing to accept financial recommendations that we made because they're worried about their budgets. And thirdly, not accepting findings of avoidable death. All those things are the act of somebody who's scared and who's under too much pressure, and isn't really being made from a sort of balanced, sensible space of actually what's the best thing to do.
Thank you. Just one quick question to you, Matthew Taylor, before closing. Obviously, as leaders within the NHS, there are many things, as we have discussed today, but we're also seeing incredible changes within medicine. We're seeing a turbulent political space and also many societal expectations rising, perhaps beyond where they beyond the realism that can be delivered as well. How do we ensure that we have got leaders that are able to address those issues? Because that is also about creating a safe environment through which people can enter.
Yeah, well, Rebecca talked about the proliferation of different kind of regulatory bodies, Care Quality Commission, Healthcare Safety Investigations Branch, National Freedom to Speak Up Guardian, Patient Safety Commissioner, Parliamentary Health Service Ombudsman, Health Watch England, Local Authority Overview and Scrutiny Committees, NHS England, professional regulators, and I could go on. So that's all happening. But actually what we need is, I think, give leaders the greatest scope to speak openly to their public. And there's an interesting contrast, I think, here between local government and health. Local government has had to make incredibly difficult decisions. We both live in the same city, over many years. But it has had to do that, and it has done it, and it has had to do it by saying to the public, we have a limited resource, and therefore we're going to have to close the library or do this or do that and focus our resources on our statutory requirements. Health service leaders don't have that legitimacy, and I don't think often they have the kind of permission to have those open conversations with the public. Now, I think through integrated care partnerships, there is the scope for us to learn from local government and to have those more open and honest conversations with the public, which is partly about being honest to the public about risk, but it's also about the role the public themselves can play, because they are critical to improving the quality of what goes on in the health service. The empowerment of patients is absolutely central to the future of the health service. The innovations that most excite me are the ones that do empower patients, give patients a greater sense of agency. So it is not, when I speak as a representative of leaders, I don't want to reduce accountability. I want more accountability, however, downwards and outwards, and less compliance upwards.
Okay, thanks very much. Right, we've got about half an hour left. We'll finish at 12. So.
Yeah.
Right, Paulette is next.
Yeah. Good morning, both. Can I start with Matthew? I've got two clear questions, and I think one is for yourself, and the second one will be for yourself, Rebecca. Right, Matthew, it was music to my ears. I sort of know how you think, and others, and King's Fund, because I do that work. I don't know if I should declare it, where I sit down and work with NHS leaders, e.g. read some of the issues they're having, and I see the hesitation and the difficulties that they are grappling with at this moment in time. So I'll start there. So Matthew, you made a fantastic point, and you keep saying it. You say we need to be more open to the public about risk and about patient safety. So my question to you, we've talked about regulating managers and leaders. Is the registration and regulation of NHS managers by a professional body or a college or equivalent now needed to achieve better patient safety, where patients can really understand what the risks are and to improve operational efficiency?
I'll try and be brief. I think NHS leaders are entirely open to the idea of some kind of regulatory framework for NHS managers, although let's remember that more than half NHS managers are already regulated as clinicians. Yeah. I think two things. One is we need to be really clear about what we're trying to achieve here, and the relationship between professional standards and other issues around, for example, leaders who've failed and then being disbarred. What exactly is it we're trying to do here? But then secondly, I'd absolutely echo Rebecca's point. If we are to create something new, some new way of recognising leadership and regulating leadership, let's put it in the context of all the other regulatory systems. Let's just not do what we always do, which is just to add another ingredient to the soup in the hope that it will improve it. Let's stand back and say, what are the ingredients that are most likely for success? So yes, we're open to it, but let's look at it in the overall context of regulation. Let's make sure that if we do create a body of this kind, we are clear about what we want it to achieve.
And and this is just my last quick point because it really touched me. I think that's a point of the day. The bit you talked about, we need to be open to the public about risk. If there was one clear thing you wanted to give to this committee to say that we need to recommend to ensure that we are doing just that, saying that we need to be open to the public about risk, what would that be?
It would be that the avoidance of risk does not always improve the overall outcome for patients. And if I can give you an example of this, during junior doctors' strikes, I visit hospitals, and hospitals feel like, in some sense, more functional places when junior doctors are on strike. And that's because the consultants are not doing their outpatients clinics or whatever, they're in the hospital. Now, that means in some ways the hospital runs more effectively. It also means that the backlog is building up, the waiting list is building up. Now, the reason for that is because more senior members of staff are more willing to take risks. They have greater confidence in doing that. I was in a hospital a couple of weeks ago where they have people in the emergency department waiting medical assessment. These people are overwhelmingly elderly, frail people. And the hospital manager said, if my consultant gerontologist is on duty, he will go down this line of patients and he will work out how to discharge each of them, because he knows that to admit somebody like this, an elderly, frail person, to hospital is almost never good for them, will lead to them being deconditioned and could lead to them also getting trapped in hospital, which, is a real issue for the hospital and its resources, etc. If, however, a junior doctor, less experienced, under pressure, goes down this line, they're quite likely to recommend that these patients have tests, which could be intrusive, and that a couple of them will be admitted, because the risk of admitting is much lower than the risk of discharging, and then that patient dies, and the relatives understandably say, well, you didn't do the right thing. I spoke to another hospital leader the other day, and I don't want to. It is an anecdote, but who said they'd been into a maternity ward, and it felt that an enormous amount of time now was being spent on compliance, rather than being spent with patients. Now, I don't want to say attest to the truth of that. That's one story. But what I would want you to understand is that sometimes the systems that seek to minimise risk do not lead aggregately to the best outcomes for patients, and that's something I don't think we always give proper consideration to.
Fantastic, thank you. And my very last point is to you, Rebecca. It's something that your area where you work, that they said the Parliamentary and Health Service Ombudsman expressed concern about the impact of introducing further regulations of NHS leaders in an already complex and overstretched system, which I think you've articulated clearly. How will residents, let's bring it back to Joe Bloggs, residents, ever get confidence in a group of leaders where additional regulations are being resisted?
So thank you for the question, and I won't kind of repeat what I said. And Matthew's kind of really articulately talked about the need not to place more burden on an already complex and overcomplicated system. But I think that there's a sort of point of substance as well, which is that, and it kind of comes back to the previous panel and what General Messenger was saying, because it's actually not the job of the regulators to improve leadership in the NHS. It's actually the NHS's job. So yes, you could look at a different system and you could consult on it and make sure that it was connected up to other sectors and so on and so forth, and you could try and deal with the fact that it's already a bit of an overcomplicated system. But that's the wrong end of the equation, I think. I think you'd start by saying, well, actually, what does good leadership look like? What standards are we setting out? What culture do we want? And worry later about whether you then want additional regulation to ensure that you've got what you asked for. But I think that's the starting point, and that's where I think the conversation needs to be.
So I'm going to hand it back to the chair in a sec, but I've got to ask you something else. We are struggling out here as a public. Everything you're saying makes absolute sense to somebody like me who understands the health service. To somebody who's out there listening to this today A lot of it sounds like we're protecting ourselves. Mistakes are still happening, things are not going the right way, and all we seem to be doing is making excuses. If there was one thing you could give us as a committee to say the Parliamentary and Health Service Ombudsman would like to recommend amongst all the flurry of things you guys have talked about today to help residents out there understand the direction of travel, because, you know, Matthew articulated all the different committees and groups. People are just confused. What would that be?
I think it's a very good question, and I think the vast majority of people who are out there who are listening to this session don't know anything about the health service regulatory landscape, or I hope not, and it sits away from their experience of the NHS. I think the critical difference that will be made to people who are NHS users is an improvement of their communication with the NHS. It is the key thing that we see in our casework over and over again is poor communication. It comes in the Kirkconnell reviews and in other areas of investigation. It's not just about what happens when things go wrong. That's critical, where we see a lack of transparency. It is also what happens before then, when people are giving views about what's going on with themselves or their loved ones. They're not listened to. One of the cases in our broken trust report was about a man who came to an emergency department multiple times with his mother. Symptoms weren't listened to, symptoms were not taken seriously, and she died of a stroke, which was entirely avoidable had they been listened to and had treatment been administered earlier. And it's all about being listened to, being communicated with, and having that honesty of engagement. We welcome the government's agreement to review the duty of candour, which we have said for some time is not being properly implemented. And we call for that as part of our Broken Trust report, and we look forward to contributing to it. And that, we think, lies at the heart of the trust between users of the NHS and the people that they work with.
Thank you, Matthew. Chair, back to you. Thank
right,
you.
Super. Right, we've got 20 minutes. 20 minutes, two people. Do the math, as they say. Paul Blomfield next.
Okay, thanks, Chair. I wonder if I could return to the theme that I did explored with the first panel in terms of the role of whistleblowing in patient safety, and I recognise that that's just one strand. And I very much recognise the points about you make, Matthew, about safety and risk. But nevertheless, I think one of the things that shocked the general public when they were looking at the lectures was people knew things were going wrong. They voiced those concerns, but they weren't heard. And the stats, which I won't repeat, from last year's NHS survey indicate that remains a significant problem. And actually, I think those numbers were worse than they had been in the preceding 4 years. So it's going in the wrong direction. I wonder what reflections, perhaps if I could start with Rebecca, you have on how we address that point and shift the culture.
Sure. So thank you for the question, it's really important, and thank you also for using the phrase, it's just one strand, because I think I'd start by saying that the strands are quite interwoven. So I would say, in listening to concerns about the NHS, there are kind of three core channels. I probably have this, but I'm going to group them into three. So there's already talked about listening to patients and families and carers. Listening to staff, we've also talked about that in terms of the freedom to speak up Guardian regime, and we've also talked about other initiatives like Martha's Rule, which goes back to families and patients. And then there's whistleblowing. And I think the thing I wanted to say was they're kind of interwoven, because if one bit doesn't work, there's more pressure on the others. If we listened more to patients and to staff, we wouldn't need whistleblowers. If we listen more to staff, then we wouldn't need to place so much burden on patients' families. So I think it's quite important to see the landscape as a holistic one. There have been a lot of quite well publicised cases of whistleblowing, not moving away from the Letby case, but there was Dr. Peter Duffy resigned from the NHS last year after 42 years in his career, and that was his retirement was on the back of being referred to the GMC on numerous occasions, Employment Tribunal. But this was somebody who'd been elected as the doctor of his whole trust, the top, whatever, the most well-regarded doctor in his trust. He'd been given an MBE for services during the pandemic, very well regarded. Just last week, there was a report of 105 cases being investigated at the Royal Sussex by police on the basis that earlier whistleblowing claims had just been dismissed as being made in bad faith, quote unquote. So what I'm going to say is that this comes up a lot, and when it does come up, we see a lot of defensive action by the NHS, and I think it undermines trust. Because every single one of those headlines has patients and families out there thinking, well, something's going on, and why is so much energy being diverted into trying to silence the whistleblowers as opposed to actually looking into what's going on in the first place. So there is something there that isn't working in terms of balance. There is a view that the legislative framework is outdated and needs to be looked at. In Scotland, the Scotland Public Services Ombudsman does have powers in relation to whistleblowing. There have been numerous private members' bills here to look at setting up some national office for whistleblowers, which would have powers to set standards, provide information and advice, and critically comply, whether forced compliance, where organisations don't have a proper infrastructure to support whistleblowers, and maybe also initiate prosecutions. So that's an important conversation. But I think at the moment, without consistent, again, that word again, without consistent support for whistleblowers, when you see the headlines, I think it breeds distrust.
Well, I agree with every word of that. When I make the 2 points to add to it, it's not about taking away in any way from what Rebecca said. But first point I just want to make is that hospitals, other NHS trust systems are big and complex organisations. There are an awful lot of complaints and there are an awful lot of staff concerns. So it isn't simply about, well, how do you respond to all of these? It's how do you have the mechanisms that enable you to understand whether these are fair, whether they're right, what should be done about it. So that's a capacity challenge. So I just want to say it's not simply a matter of the fact that you sit here and everything's fine and then someone complains about something and you ignore it. There is a constant background noise of people, having concerns about what's happening because, we're dealing in life and death situations and we are not, unfortunately, at the health service at the moment able to meet the expectations that the public have. And we also know from staff surveys that many staff, we just saw this last week in a survey of why doctors are in the NHS, that they are unable to provide the level of care which they came into the service to provide, that is a kind of endemic experience for them. So I absolutely agree, and as I said earlier, it's all the leaders I speak to recognise that responding to patient concerns and responding to staff concerns is not a kind of hygiene factor away from the main business of improving the quality of care. It is intrinsic to improving the quality. It's one of the ways in which we can drive change and should drive change in the organisation. But I wouldn't want us to underestimate the capacity issues that are involved in responding to the level of concern that a large organisation dealing with life and death issues and a staff who feel very often overstretched all the time that involves.
I think I very much take that point, and I think, Rebecca, you talk about defensiveness. The NHS isn't unique. Big organisations, small organisations are instinctively defensive when challenged, and I guess the challenge that the NHS has is how it overcomes that and recognises that, say, with patient complaints, there's an overlay of grief sometimes and trauma, which is kind of looking for blame where it doesn't exist, and so there is an instinct of not learning. As I think Rebecca put it, not learning from mistakes. How do we How do we get past that, Matthew?
Well, I wonder what Rebecca. I mean, your role to ask questions, not mine. But I wonder, Rebecca, the extent to which you think that part of the challenge of speaking up is that people are more likely to speak up if they think something might happen as a consequence of speaking up. So it isn't just that you need to feel safe about speaking up. You need to feel that there is a point to speaking up in terms of.
The NHS survey demonstrated that people felt neither.
Yes, exactly. So again, I don't want to be a broken record, and I'm not saying this is all just about resources. There are important issues about leadership and patient safety and all those systems. But part of this is that staff have to feel, well, it is worth making a complaint and taking the risk that might be involved in that speaking up, because I think there's an opportunity for things to improve. But if you think, well, actually this is simply the reality that we have to cope with, that is going to discourage you, because you have the hassle, but there's not much chance that a great deal is going to change.
Can I just follow up on that in terms of a point that you have made earlier, which is about too much time is spent looking up in the NHS, and you talked about ICBs and the tension that they report between NHS and local government. I mean, when I talk to my local ICB, which I do every month or so, the real tension is, they're kind of dealing with that and it's inbuilt into the system, but the real tension seems to be between local decision making and nationally imposed decisions. And I wonder how far, you're nodding at that and it kind of reflects, I think, what you were saying, but I wonder how far there is a culture at a local level which is, what's the point in us speaking up? Because, we are a top-down organisation. Judgment locally isn't respected. Is that a factor?
Well, I certainly think that the culture of the NHS is not one where, if leaders are frank about the challenges that they face and the risks that they have to balance, that is not particularly career enhancing, I would say. Partly because of this accountability issue, because it is not clear what your local accountability is, it is clear what your central accountability is. I want to emphasise that this issue of central, of the kind of hierarchical nature of things, I do think that NHS England is doing really important work to rethink its operating model, to try to be more permissive, to respond to the way in which systems work. The politicised nature of the health service is the big issue here, and one of the reasons that we protect the NHS and the public care so much about its principles is because it is this national institution, and it is something we feel so politically deeply about. But the flip side of that is this constant short-termism, and the fact that we all know it was political horse trading that led to planning guidance being published the day before the planning year began, which is everybody knows is a complete nonsense. So that kind of the way in which the relationship at the very top of the health service, the politicised nature of it, does take up an enormous amount of energy, which could be better used, in my view, in cultivating those local relationships and engaging with the public. And as Patricia Hewitt argued in her report, which you commented on in your own report, which I think remarkably similar kinds of conclusions, is that we created integrated care systems, we created new integrated care partnerships, but we haven't yet created at the national level the kind of operating model that goes with the intentions of those integrated care systems.
A lot more to explore there, but I think the room.
Yeah, right. Thank you very much. Right, let's move on. Caroline, finally.
Thank you, Chair. I wanted to come back to what you said, Matthew, about risk, because the balance of risk, particularly in relation to ambulances and ambulance transfer times, has always something I've been advocated on as a backbencher and then as briefly as a minister, because the people at most risk are obviously the people who haven't got their ambulance yet.
Yes.
But if you run a risk balance system, inevitably you have increased the risk somewhere in order to spread it out more evenly, and that will have an adverse consequence on an individual somewhere, even though the overall effect may be to make it safer for the population. For an individual it may not always be. We also have a tendency to judge people through a retrospectoscope and say, well, it was obvious but rather than recognising there were hundreds of people came with the same symptoms, almost all of whom didn't have a serious problem. That can lead to defensive medicine, which, as you've alluded to, also then leads to unnecessary investigation and an opportunity and resource cost for other people. So how do we get that balance right?
Well, it's such a brilliant question. I mean, I would just say the very recognition of the need to get the balance right, and that is the responsibility of leaders, and we need to give leaders the scope to be able to get that balance right and to talk explicitly and openly about how they're trying to get that balance right, would be what I would recommend to you. And I think at the moment it is quite difficult to do that because, as I say, we have a culture in which, if you are on the board of a system or a trust and you have the things you have to comply with, you don't have the scope to say, well, I'm going to comply with 80 of them, but I'm not going to comply with the other 30. I just can't do that. You have no ability to say that. You have no accountability mechanism that would allow you to say, well, on behalf of local people, I'm doing that, or on behalf of my local partners, I'm doing that. So I think what you've said is absolutely right, and I think one of the things I would encourage the committee is to explore how it is we can give leaders more permission to lead in opening up some of those debates and engaging the public and their staff and others in those kinds of conversations. That is what leadership should be all about.
Thank you. Yesterday, the CAS report was discussed in Parliament, a statement by the Secretary of State on the CAS report. One of the things that was highlighted in that, there were many things highlighted in it, but one of the things that's highlighted in it was a failure of managerial staff and senior leaders in the NHS to be able to make people comply with contractual compliance things. So, for example, the CAS report wanted to look at the outcomes for children who had gone through the GIDS clinic, the Tavistock, and had then gone into adult care. And there was a refusal by some people working in adult care, even with the protective blanket of a specific SI in Parliament, is to give them legal cover to make sure they could do so, even with direction from NHS England itself to the trusts, the letters from the specialist commissioning officer, they still didn't provide the data. Is that the managers don't have the levers to enforce compliance? Because you've talked a lot about compliance. Is this an example? They just don't actually have the levers to enforce compliance, even if they wanted to.
Yeah, I'd have to admit I need to know more about the specifics in relation to that. I would say, however, that I think that data is an extremely important part of this. That the more that we can have accurate and credible data, and the more that we can open up that data and share it with the public, I think that generally people in the health service want to do the right thing, and if they think there is credible and strong data which identifies the fact that the outcomes are not as successful, or that they are performing much less well than the average, then people want to respond to that. But you raise an important question about the capacity for managers to ensure compliance in particular circumstances. It's one I have to take away and look at.
Okay, I mean, I think
Rebecca may have more to.
I don't have. I wouldn't be able to speak to the specifics of the case. Broadly speaking, I note that some of the findings that you see repeatedly in the investigations that we've been talking about are about lack of ability to follow basic national clinical guidelines. So I don't know whether there's a read across there in terms of capacity and time, but I don't have knowledge of the specifics to talk to the case that you're mentioning.
Okay, thank you. You mentioned data. The NHS in of itself is a gold mine of data, because virtually everybody accesses the same health service, has their NHS number. The anonymous data that the government should really be able to use to improve patient care is not being used to its fullest advantage, in my view. I wanted to ask you a question about people's understanding of the leadership structure. So we saw with the Lucy Letby case a situation where 7 paediatricians had written to their senior managers within the trust to raise concerns about what was going on. And we heard how, sadly, a number of babies died. And the question then became, when 7 paediatricians are all saying the same thing, Why were they not listened to? Something Rebecca's talked about, being listened to. Do you think people understand if the trust board don't agree with me and I think there's a problem here? Do people understand where the next step is? Where can they go if their trust board is not listening? Think it's even clear? Think it's clear who they would go to next?
Do you want to go? I mean, I will respond to it, but do you want to go first on it?
When you say people, you mean the paediatricians, or as
Yeah,
opposed
I mean, this was this is one example. I'm sure that if you look detail, there may be other less high profile examples. But it was an example where a group of individuals were banging their head against a brick wall, really, and raising concerns and not being listened to really desperately tragic consequence. But where do they go if their trust board's not listening to them? Where would they find a organogram that shows them, okay, if they're not listening, go here, go there, go get up to our apprenticeship. Where would we go?
Well, I think in a well-run trust that will be very clear, because if your objective is to make sure that you've got all that information, that you're listening to your staff, and that you're promoting the escalation of safety concerns issues, you're making it very clear to people what the pathways are. Not only that, but you have a board that is able to really understand the granularity of what's going on where necessary, so they're engaged in those communications, and they have sufficient understanding that they can engage with and listen to safety issues. That ought to be something that happens proactively.
But
I agree.
wherever you have difference, you will have variations of good, and you have variations of bad. And we've seen the Tavistock that had an inadequate rating, not aware that any manager has been sacked from the Tavistock for their inadequate rating, and reports which speak for themselves yesterday. We've got the situation with the Letby case where there was very, very, very tragic consequences to paediatricians en masse not being listened to. So yes, it may be the case that if the trust is well run, it's all very simple and very straightforward. But all trusts will never be all well run, because in reality you have difference. You will have people that are not good at their job. So where do they go next?
I think it's important to have clear responsibility. I mean, that it is clear that there is somebody on the board who is leading in relation to patient safety, who is someone that ultimately you can go to if you feel that all other avenues are closed to you. I think that is...
what if they don't listen?
I think if you go through the board and they don't listen, we have other mechanisms. We have the freedom to speak up guardians, so that is one route. You can go through your professional organisation. It's not a situation that we should be getting to, that you feel that there is absolutely nowhere that you can go within that organisation. And we have put in mechanisms to try to ensure that isn't the case. So I think that we will look forward to what comes out of the inquiry into Countess of Chester in particular, because I think what you identify is a very important question, which is what happens when it feels like you have exhausted every avenue. I think generally speaking, the ways in which you escalate these things are laid out. Whether or not they always work is another matter. But I do think that generally well-run organisations will be clear about the process and where you can go, and where ultimately you can finally take that to board level if you feel that nobody else is listening.
And hence my comment earlier about the interconnectivity between listening to your various stakeholder groups. And that, I mean, ultimately, yes, you ought to have better support and infrastructure for whistleblowing. But that oughtn't to be really where we're focusing. We ought to be making sure it actually works, given your point that it will never all be perfect. But I suspect there's more room for improvement there as a starting point.
And if people in the end feel that they have to go outside the organisation to the police or to the media or anybody else, that is a sign of failure within that organisation. There's no question.
Totally.
Thank you. And if the Chair will allow me for one last very quick question. Rebecca, at the beginning you talked about sharing lessons. And it seems to me that in such a massive organisation, there will be lots of things to learn. And if you group them together, they become in some ways so generic that they're not necessarily all that helpful to people to listen to and quite repetitive. When they're quite specific, they may be more useful, but they're more difficult to share because there are so many of them. I'll give you an example. As a paediatrician, in my very first paediatric job, I left a baby one day, went home, and there was a mistake made by the registrar. after I'd left, and that had a very poor outcome for that individual child. And every time I teach junior doctors about the process that was that specific process, I will tell them about that specific baby, not the details of the person, but the story of what happened. But I can't share that detail with every other paediatrician in the NHS very easily, and everybody else who's got a similar story can't share that with every other paediatricians in the NHS. So how do we get lessons to be specific enough that they're useful to the doctor or nurse or other clinician, and not so generic that they just become bland, but recognise that there are so many different lessons to learn that we'd have to sit and read for days and days and days and days to go through them? How do we select them? How do we get that right?
I think that is part of learning, though. I think if you have a culture of learning and wanting to improve, you frankly find a way to disseminate that information better. You shouldn't be scrolling through loads of papers and long reports and bibles of cases or whatever. The organisation should be saying, we recognise that is critical learning, and we will find a way of sharing it in a way that makes it accessible to people in real lives, in their professional contexts. I'll give you a couple of examples, completely different kind of examples. One is that I know that some of that there have been interventions designed around making sure that all policies in a hospital are absolutely updated, so that if you go on the website you get the latest whatever it is, without understanding that actually, because of poor Wi-Fi, what staff were doing was downloading outdated hard copies and using those because they come to hand. So something about recognising what people are actually doing on a day-to-day basis, and making sure that when you promote learning, you're understanding how people can reach out and how they can learn, and what their best way of understanding that is. But I also want to come back to the point that I made earlier, and I'm sorry to dwell on it, but it's just something that we see a lot of, and it's really important. We quite often see a case where somebody has died as a result of poor treatment for whatever reason. And this person has an underlying condition which would have meant that at some point they were going to die in the near future, perhaps in a matter of months or years. And we quite often have a debate about whether that's an avoidable death. That's just the wrong conversation to have. Because for a start, it's not the death they should have had. It's not the warning their family should have had. They haven't had the quality time with them to say goodbye, and therefore they can't heal and get over and accept what's happened. Instead of which we have a trust saying, oh no, it wasn't an avoidable death. So the learning from that never happens, because they're too busy batting away a grieving family who need to find a purchase in the truth of what's happened, instead of looking at, I suppose, their statistics in terms of avoidable death. It is a cultural thing. It is about trusts and the NHS saying, okay, we're not going to worry about being defensive. We're going to say what actually happened, and how do I fish that out of this case and make sure that everybody understands it, because it's really important. If you say, actually, no, it wasn't an avoidable death because she had cancer anyway, no one's going to learn it, because no one's actually ever going to be given that fact and shared the importance of it, because the trust says it isn't important, she was going to die anyway.
So just in respect, you've gone back to trust level again, haven't you? And so for me, I don't work now in the trust where I was working when that happened. And so I can share that information with, and the other doctors involved will presumably share the information with places that they work, but that doesn't stop someone in Cornwall having the same problem because no one's worked there. How do you spread things out so you don't have the same mistakes being made in different hospitals around the country?
I think there are different mechanisms, and we have now the new PSERF system, which is supposed to be a system which enables us to understand when things go wrong, what has gone wrong, in a way that is not around blame and is around learning. So the critical thing is learning. We also have programs like GIRFT, which are around looking at data in order to ensure that we do things in the best way that we can do them. So I think your point is absolutely right. We have to understand, well, what is the nature of the learning? Is it organisational learning? Which is around the culture of this one specific organisation, or is it learning which can contribute to rethinking the way in which we undertake a particular clinical pathway? So we need to be clear about that. But just in response to Rebecca's point, as it's my final contribution, I suspect, you're absolutely right when you say about avoidable deaths. But I think we also have a situation where I hear very often from people, from loved ones, that their loved one had indicated they did not want more interventions. They did not want to go back to emergency department. They did not want to be admitted to hospital. And they've made that clear in their care plan. But still, the way the system worked, in often a kind of risk avoidance way, led to those interventions and those admissions that they didn't want to have. So, that's part of this story as well, is how do we ensure that when people are clear that they've reached a stage where they want to minimise medical interventions, they want to return home if they can be with their loved ones, that we can give them the dignity that they want.
And that comes back to communication again.
Absolutely.
I agree.
Thank you both. This has been a good start to this inquiry, I hope. Really grateful to Matthew Taylor and Rebecca Hilsenrath for your evidence. Big day in the House of Commons. Downstairs on the other channel, on the main channel at 1:30, will be the Smoky and Vape Spill, where people watching can see NHS leadership in action from the Prime Minister this time. Order, order. Right, I'm going to do this interview.
The Grimmond Room. Portcullis House, the Grimmond Room. Portcullis House, the Grimmond Room.
The proceeding has ended. 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 The proceeding has ended.